مساء الخير جميعا. Mute yourself.
السلام عليكم، مساء الخير دكتور عادل.
حياك الله. حيا الله الجميع.
دكتور رياض, good evening. Good to see you again. So maybe in this nice evening, I would like you, Dr. Adel, to lead the introduction of this ground round by introducing our first speaker, and then I'll go with the second later on.
Sure. Good evening, everyone, and thank you for joining us. We're lucky today to have two outstanding speakers in this MENASO grand rounds. As you all know, this grand rounds are endorsed by the World Stroke Organization and American Heart Association, and sponsored by Medtronic and Boehringer Ingelheim. Just some housekeeping, if you like, remarks. Usually we leave the question for at the end of the sessions. You can type your questions in Q&A section. And before delaying anymore, I'd like to thank my chairman, Dr. Saif A AlZaabi, who's joining us from Oman. He is a Canadian and American board-certified interventional radiologist and fellow of the Royal College Physicians and Surgeons in Canada, and he's the chief of clinical program integration, director of international collaboration office, HealthConnect in Oman. So welcome, Dr. Saif. Myself, I'm Adel Alhazzani, a stroke neurologist and associate professor of neurology in King Saud University. Our first speaker joining us from US is Professor Pooja Khatri. She is a neurologist, well known in the stroke world, and a professor of neurology and rehabilitation medicine in University of Cincinnati. Has been a principal investigator in many of the recent trials. Her interest is in acute stroke, stroke in young, and reperfusion therapy. Professor Pooja Khatri obtained her bachelor degree in biological medicine from Stanford. She did her MD degree in Chicago. Then she moved to the East Coast to Pennsylvania, where she did the neurology there. Then came back to Cincinnati, where she did her training in stroke. Subsequently, she had a master in epidemiology from Harvard, and she received many recognition and awards. Without any further ado, we'll have Dr. Pooja Khatri, if she's ready, to talk about the microbleeds and acute ischemic stroke management. Pooja, the mic and the floor is yours.
Hi, everyone. Thank you for having me at the MENASO Cerebrovascular Grand Rounds. I appreciate the opportunity to speak with all of you today. I'm going to be speaking about microbleeds and acute ischemic stroke management. These are my industry disclosures. None are really relevant for this talk. So when we think about hemorrhage in the setting of making our thrombolysis and thrombectomy decisions, the biggest thing we usually think about is making sure when we get that patient with an acute sudden onset of neurologic deficits, making sure that they don't have a hemorrhage. Our guidelines spell out for us that all patients with suspected acute ischemia or acute strokes should receive emergency brain imaging evaluation on first arrival to a hospital before we initiate any therapy, and that we should do this as quickly as possible, because the faster we treat, the better we make people. So we typically, whether you're in a low, middle, or high income country, we all typically use non-contrast CT scans, with rare exceptions, to exclude intracranial hemorrhage before IV alteplase administration. And we see a variety of things when we get that initial CAT scan. One of the things that we might see is hemorrhagic transformation of a cerebral infarction, uncommonly seen acutely, especially if the timing was right. But sometimes you've got a patient who had a silent stroke And then it's that hemorrhagic transformation that leads to symptoms that leads them to come to the emergency department. Sometimes it can be a bit subtle, and you see heterogeneity there in the ischemic bed, like in this picture on the left, that first one there. Sometimes it's a big ball of blood, like a primary intracerebral hemorrhage. We've all seen those. And then sometimes it's subtle, such as subarachnoid hemorrhage. And that's the one that we all could lose sleep at night if we accidentally miss. And that's why we look carefully at our CAT scans ourselves. And then finally, also subtle sometimes can be a subdural hemorrhage, especially if it's subacute, because it can sort of blend in with the parenchyma. But you can see this one pretty well here in the fourth picture. Now, it's interesting because we talk about history of intracranial hemorrhage in the package labeling of Alteplase, as well as our guidelines. But when we're talking about that, we're really not talking about microbleeds. This wasn't the intention of that exclusion, and it has to do with the history in which we were doing MRIs far less frequently when the pivotal trials of thrombolysis were being done in the late 80s and early 90s. So those with a history of intracranial hemorrhage were excluded from the randomized trials of TPA. And since then, there have been very few observational studies on this topic. The guidelines, the European stroke guidelines mention that there was one series of 1,212 patients in which 7 had a history of intracranial hemorrhage. None of them developed symptomatic hemorrhage or died. There are also many case reports, but it's hard to do too much with that. And as you might imagine, the most recent guidelines that come from the European Stroke Organization that address this and have a dedicated guideline specifically on intravenous thrombolysis talk about how there's basically insufficient evidence. Instead, they give an expert consensus statement. And I think their consensus really reflects how I view this, which is that intravenous thrombolysis is appropriate in selected cases. 8 out of 9 of their members of authorship voted that they would pursue thrombolysis in selected cases, specifically if a long time had elapsed since the hemorrhage, or if there was a non-recurrent or a treated underlying cause. So for example, an aneurysm that had been clipped, or a provoked hemorrhage on warfarin where the patient is no longer on warfarin, things like that. And so I routinely treat these patients, and I think that most experts would tell you the same. Now, cerebral microbleeds are a whole different story. They're a bit tricky. Oftentimes, we don't even know if the patient has cerebral microbleeds. We don't see these on CAT scans, but we see them on MRIs. And when we do, they're small, less than 10 millimeter, typically intraparenchymal bleeds. You can see in these pictures on the right that they make the brain, especially if there are several of them, look a little bit like Swiss cheese. They're presumably from microvascular fragility and or increased permeability across the blood-brain barrier. And the most common scenarios by far, as you all know, is we see them predominantly in the deep areas of the brain when there's chronic hypertension, and predominantly in the lobar areas when there's amyloid angiopathy. There are lots of uncommon causes. And as I was reviewing things for this talk, I was struck by just how many uncommon causes there are for seeing microbleeds emerge acutely as well as chronically. Roughly 20 to 40% of patients have microbleeds among ischemic stroke patients. And their risk factors include advanced stage and vascular disease. Because it comes along with chronic hypertension, it's not surprising that it's coexistent with lacunar infarcts and white matter disease, particularly for those with amyloid angiopathy. Being an APO lipoprotein E4 carrier is a significant risk factor. And then notably, lower cholesterol levels and statin use seem to be risk factors for microbleeds, which is a very interesting topic in and of itself. Now, the way we end up seeing these microbleeds are when we do a GRE sequence on MRI. And that's specifically a sequence that's sensitive to the susceptibility effects of iron atoms contained within the hemosiderin that deposits with these microbleeds. Now, that's GRE. There's also susceptibility weighted imaging, or SWI, which we often refer to as the SWAN. And this typically has a much higher spatial resolution than gradient echo. and it sort of increases the conspicuity of the other iron-containing structures as well, like the cerebral arteries and the veins and the basal ganglia. There was concern that maybe, swans were overcalling the number of microbleeds, but at this point, I think there have been a couple good studies suggesting that swan is actually more reliable and sensitive. It can help us sort out more clearly when there's a vessel. And I think this is a great example of how it just kind of looks a little fuzzy, that microbleed on GRE. And we might not have called it in that picture A, but then in picture B, it stands out much more distinctly. So we kind of think the real answer is the swan. But the reality is that the far majority of studies to date that have examined the risk of microbleeds and bleeding in the context of TPA and endovascular therapy and studied it more generally have done it in the context of GRE. So do keep that in mind. It does make things a little trickier and messier with our literature. Now, what about thrombolysis and history of microbleeds? So alteplase and microbleeds. Like I said, pivotal randomized trials lack microbleed data. Only observational studies have existed to date to address this. And there are a lot of really nice, thoughtful studies. Some of them do suggest to us that having microbleeds increases your risk for alteplase. I would say that's where the majority of the studies go, particularly if they have a big enough sample size, but some do not. And I think that the best summary of these data, and I should note that those studies that I listed are all detailed in the appendix of the American Heart Association, American Stroke Association guideline for acute ischemic stroke. I'm specifically referring to the 2019 update that was published in December. I think the summary is that, first of all, we don't recommend administering TPA without first obtaining an MRI to exclude microbleeds. That's probably the most important message. The far majority are not even going to have microbleeds. And to the degree that they do, as I'll show you, the data are not clear-cut about how to handle that anyways. So the punchline of all those studies that I just showed you on the previous screen, which are well summarized here, are that the risk of symptomatic hemorrhage in patients with greater than 10 cerebral microbleeds is consistently reported as significantly greater than those with no cerebral microbleeds. So in other words, 30 to 40% versus 1 to 4%. So it is quite a notable difference. However, these data are based on less than 50 patients constituting 2% of these series. So very limited data, wide confidence intervals, but you tend to believe that clearly there's an increased risk. The issue though is that there's been no randomized study of this. And so because there's a higher risk of symptomatic hemorrhage doesn't necessarily mean that the patient isn't going to be better off with treatment with alteplase as opposed to not being treated. Quite comparably, one might think to, for example, having aspirin or aspirin and clopidogrel on board, where we believe that the treatment effect probably stays intact, but clearly there's an increased risk of symptomatic hemorrhage, small but real increased risk of symptomatic hemorrhage. So at this point, there's no determination based on the data that we have on the effect of baseline cerebral microbleeds on treatment effect of alteplase when we have that data. Now, it's really interesting because a year later, our European colleagues published the European Stroke Organization's guidelines on intravenous thrombolysis. This was dedicated just to thrombolysis, as I was mentioning. So it hit some questions in more detail. And one of the PICO questions they asked is, in patients with acute ischemic stroke who are within 4.5 hours of duration and have microbleeds, does thrombolysis with alteplase link to better functional outcome than no thrombolysis? Well, not surprisingly, they did say that if there is a cerebral microbleed burden that's unknown or known to be low, we suggest intravenous thrombolysis. Interestingly, unlike the previous guidelines I just mentioned, they did conclude that for patients with acute ischemic stroke within 4.5 hours who had microbleed burdens they're reported to be high, greater than 10, for example, they suggested no intravenous thrombolysis. The quality of evidence they report was low and the recommendation strength was weak. And I think it goes to show that it's a tricky area to land on. They did have one more study than the prior guidelines from a year ago, and I think it's a really important study worth talking about briefly. This was led by Schlemm and colleagues and published in Stroke in January 2020. It was a very thoughtfully, carefully done study, and I recommend reading it if this is something you'd like to dig into. What they did is they extracted the parameters or the assumptions of rates of outcomes using a recently published meta-analyses, two of which were on my first screen. And they looked at 3-month modified Rankins and estimated 3-month modified Rankins, I should say, for different groups of patients with ischemic stroke. They were defined by their microbleed status, whether they had greater than 10, less than equal to 10, or an average number. And the average, I don't recall specifically, but I want to say it's 1 to 2. The occurrence of symptomatic intracranial hemorrhage, yes, no versus at risk. And then the treatment status, intravenous thrombolysis versus no intravenous thrombolysis. So they modeled this out based on the data available and then used the resulting modified Rankin distributions to estimate the treatment effect of thrombolysis in groups of patients with greater than 10 or less than or equal to 10 cerebral microbleeds. And the main findings were that thrombolysis effects on functional outcome are attenuated in patients with greater than 10 microbleeds. In fact, thrombolysis appears associated with a significantly increased risk of mortality with greater than 10 microbleeds. So it's actually potentially causing a nut harm in subgroups of patients, particularly defined by age, stroke symptom severity, and treatment delay. However, routine treatment with MRI cannot generally be recommended as long as it causes even a small additional treatment delay. And they modeled this out and said that for it to be worth doing an MRI, we would need to do the MRI within less than 10 minutes for the average patient. A few things to note here. The pre-test probability of having greater than 10 cerebral microbleeds is low, 0.6 to 2.7% in the typical patient that would come through your door. And so that's why that MRI doesn't end up being worth the time for the far majority of people. And it's actually a net loss if we did that on everybody. Now, MRI to quantify a cerebral microbleed burden would be justified only if the delay was less than 10 minutes for most patients, as I said. You can imagine at some point that maybe we would have faster MRI sequences and technology that allows us to do that. But they also mention and talk a little bit about how there are clearly subgroups that, based on their modeling, with advanced age combined with either dementia, small vessel disease, spontaneous hemorrhage, these patients that might actually be appropriate to get that delay and do that MRI. And even if that MRI takes more than 10 minutes. And so they leave this question out there of the patient who's 90 years old with dementia, who might be appropriate to again get that MRI for. However, this was a study based on modeling and many assumptions. And so it certainly informs our thinking, but it as we deal with our patients in an individualized manner, but certainly more studies are needed. Now, based on that, the European Stroke Organization actually expanded on the expert consensus and the expert consensus section to say that for patients with acute ischemic stroke within 4.5 hours, 9 out of the 9 members did suggest against systematic screening with MRI to assess microbleed burden before making a treatment decision with thrombolysis. Not surprising there. So what about thrombectomy and history of microbleeds? Well, I think it's helpful to look at this study, which really suggests a little bit of a different thought process for how microbleeds might be playing into our recanalization therapies. This was a prospective study out of Korea. They enrolled consecutive patients, 1,532, into a registry, and these patients were treated with either thrombolysis or thrombectomy. Among these patients, 595 fell into what they called the recanalization subgroup. So if they got endovascular therapy, they had at least TICI 2B3 recanalization In other words, more than 50% of the vascular distribution of the tree of that occlusion was reperfused. Or they did, if the patient was given intravenous thrombolysis, they did a 24-hour CTA to determine if the vessel that was occluded was now patent. And therefore, again, that patient would be in the recanalization subgroup. They found a significant interaction between microbleed presence and recanalization in predicting functional outcomes. So in patients in the recanalization group, the presence of microbleeds, especially a high microbleed burden of 5 or more microbleeds and a low bar location, were associated with less favorable outcome at 3 months and more symptomatic intracranial hemorrhage. So interestingly, in the group without recanalization, the association did not reach statistical significance. So it seemed to suggest, lead to the hypothesis that really where microbleeds can cause problems is when you actually open up that blood vessel. So, and ideally we hope to do that. We do that more often with endovascular therapy than we do with IV thrombolysis. So one might be more concerned in that case that we are leading to more harm. But the question is, are we leading to even more good to counteract that harm? And that's not so clear again from the study, not a randomized study. And I think the authors put it well when they say that our results do not imply that patients with microbleeds should not be treated with thrombolysis or thrombectomy for recanalization, as patients with recanalization show a prognosis that is similar and not worse than those without recanalization. So they saw no obvious signal of harm. You can see on the right here, this is the modified Rankin distribution at the top for all patients. At the very top bar shows you absent microbleeds. The second bar shows you present microbleeds. And you can see that the outcomes are comparable here for all patients. But when we turn to the lower, what we call the Grata bars, the modified Rankin distributions in letter B here, you can see that the difference in outcomes becomes significant with a p less than 0.001 for those with a modified Rankin of 0 to 2. So the data on endovascular therapy and microbleeds are very limited. There is one particular study that was just published this last year in Neurology that is the largest to my knowledge. And this is a retrospective analysis of consecutive patients, 513 of them, treated with endovascular therapy in Pisa, Italy. They found no association with clinical outcome, mortality, or symptomatic intracranial hemorrhage. Without going into all the details of the results, I can say that there didn't seem to be a pattern to even suggest that they were underpowered. So they wondered why they got such a different result from that prior study looking at the recanalization subgroup, considering that if anything, endovascular therapy should be recanalizing patients more consistently and more efficiently than TPA alone. They didn't think it was necessarily a power issue based on the sample size they had. They speculated that maybe it's because TPA wasn't on board. You can imagine that partial recanalization could have a detrimental effect. Also, the question comes about ethnic differences. We have certainly seen in Asian, especially Southeast Asian populations and Far East Asian populations, that they may be more prone to hemorrhage. And then finally, the Korean cohort did seem to generally have a higher microbleed burden. So it may be a sampling difference in the cohorts that they were analyzing. So my take-home message is significant microbleed burden is uncommon. So we shouldn't waste our time looking for it with an MRI in a typical patient. If a significant microbleed status is known, such that they have greater than 10 microbleeds, perhaps because they've had an MRI in the past, we need to weigh the risks and benefits. And we have a low level of evidence and a weak recommendation against thrombolysis based on modeling data, which certainly at this point are the best data that we have. And I think we have to consider the whole circumstance when we consider these patients and the individual and their preferences, I should add. Now for endovascular therapy, we typically recommend treating these patients regardless of any known microbleed burden. They may not do well regardless. They certainly have worse outcomes if they have microbleeds, strokes in general, but there's no evidence of harm from endovascular therapy to date based on the limited data that we have out there. And then finally, and provocatively, it seems that based on that modeling study I showed you, obtaining an MRI may be warranted in elderly patients with dementia, small vessel disease, or spontaneous hemorrhage, particularly the over 90-year-olds, maybe the over 80-year-olds, where risks might actually outweigh benefits. And I will say that I can think of a case that swayed me based on the data that I provided to you in this talk. Those data swayed me enough to take a patient where the onset time was very questionable. And I said, you know what, let's just go for that MRI. I didn't feel good about treating that patient. So I said, you know what, I just want to look at their GRE or SWAN. I can't remember which one is available at the hospital I was treating. But bottom line is the patient didn't have microbleeds, and they did have flare DWI mismatch, which could be another talk in itself. And I did go ahead and treat that patient. But I do think that's at this point fairly, cutting edge and not clearly fully delineated, and something that should be taken on a case-by-case basis. So I hope you found this talk useful, and I apologize that I won't be able to be with you for the live questions and answers in the live session, but I look forward to watching the recording later and hearing about the presentation of endovascular cases in 2020 by the next speaker. Thank you so much for having me, and I look forward to meeting some of you in person in the future. Have a good meeting. Bye.
Thank you, Dr. Khatri, for this superb presentation as usual. We'll leave the questions till the end of the session. I'll move the mic now to Dr. Saif to introduce our next speaker and next session.
Thank you for the nice presentation, and thank you, Dr. Adel, for the nice introduction and handling the first talk. Dr. Riyadh AL-Okaili is a full-time endovascular surgeon, neuro-radiologist, and a neuro-interventionist at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. Dr. Riyadh is an American board certified in diagnostic radiology with subspecialization in neuroradiology. He did his neuro-interventional fellowship at the University of Pennsylvania. He holds more than 25 years record of experience with MB and BS diploma license obtained from King Saud University in Saudi in 1995. In 2008, he has been congratulated by King Adel Al-Saud for participation in the successful separation of the Omani craniopagus conjoint twins. He also received Medical University of South Carolina Radiology Sixth Man Award, an outstanding academic achievement award in 2000, as well as obtaining the Radiology Bangit Raga Award in 2004. In 2007, he has received the Prince Abdulaziz bin Nawaf's award for scientific innovation in medical imaging. I cross-trained a station with Dr. Riyadh 2 years back when I worked briefly with him in Dawali clinics in Riyadh. Welcome back, Dr. Riyadh. With no further ado, the mic is yours.
Hello, everyone. Thank you for the invitation to present in this forum to this audience. The topic of my talk will be related to neurointervention. First of all, let's do a quick orientation. Two things. The first is how to approach this presentation. I consider two approaches. One is a tour of neurointervention that would take us through multiple topics. The other approach was to take a poster child and use it to showcase neurointervention. I took the liberty of picking the second approach, which basically is gonna focus our discussion about stroke intervention and use that to showcase neurointervention in general. But please keep in mind that neurointervention is more than just stroke intervention. There's vascular anomaly intervention, oncology disease, spine interventions, and so on. The other thing I would like to bring the audience attention to is that I could have presented this as cases and make it purely clinical, or talk about devices and technique and make it a technical discussion. However, I thought that would not be useful in a diverse group that I'm talking to, that includes physicians, nurses, technologists, and others. So I elected to do a blend of all of these, in addition to talking about the team that represents the neurointerventional team. And I thought it was important, and actually I'm going to emphasize, how does neurointervention and specifically stroke intervention fit in the overall scheme of healthcare? So this is an overall orientation to how we're going to proceed. So overview. The first part, we're going to talk about the big picture, and then I'm going to take you through the pre-angiographic or stroke intervention journey that the patient goes through. And then I'm going to talk about what we do on the angiographic table. So big picture, this is going to be divided into 3 parts. The first part, which is going to be, how does neurointervention and stroke intervention fit in the general scheme of things with healthcare. Then we're going to narrow it down and talk about how stroke intervention is related to the remaining aspects of stroke care. And then we're going to talk about neurointervention technically and specifically in the angiographic suite. So I think when we talk about healthcare, it's very difficult to illustrate how a certain aspect of healthcare is important or not. But one method is to see how it relates to high-profile clinical practices and see how it measures up to those clinical practices and specialties. For example, if I ask the audience to point out where Mongolia is, me and maybe some of you might have difficulty in identifying that. But if I told you that it actually lies between China and Russia, probably you would say somewhere over here. And I'm going to try to do the same thing with stroke. To illustrate this point, let me invite the audience to a short thought experiment. So let's take 2 investment opportunities. Let's stay away from medicine. And the first investment opportunity goes like this. This investment is related to something that preoccupies you daily. To solve this problem, it's going to cost you about $100,000. But remember that at this kind of investment, it's fully refundable. And the cost that you initially invest is going to come back to you. And then after you make your investment, there's no maintenance fees. This investment will boost your happiness by approximately 30%. And you cannot make this preoccupation go away. You're stuck with it. Either deal with it or you're going to be facing it on a daily basis. And if you ignore it, as I mentioned, you have a heavy price if you neglect it. Compare that to another investment, something that you're preoccupied with once or twice a week or once every month. And it's going to cost you to solve this problem $300,000, and it's not refundable. And after you invest, you have to keep paying 5 to 10% maintenance fee. It will boost your happiness by approximately 11 to 17%. You can make it away because you can actually navigate around it instead of dealing with this preoccupation. And you have a less price to pay if you actually neglect it. Who in the audience would choose to invest in choice number 2? Who in the audience would choose to invest in choice number 1? This is a thought experiment, but it is sort of my segue towards stroke intervention. What we're talking about here is a comparison between stroke intervention and transplant. At least in my institution, transplant is a high-profile service. and it occupies a dominant portion or slice of the budget of my institution, while stroke intervention is not given the similar attention. But let's look deep into it using the format that I just showed you. The burden of disease for stroke is a top 2 disorder. When you look at the top 10 ranking burdens of disease worldwide, it's a top 2 disorder. While, let's say, renal transplant is not a top 10 preoccupation. The price tag for stroke intervention is about 100,000 riyals. But guess what? If you invest that much, you're going to have it fully refundable with time. And you're not going to need any maintenance fees. While if you do a renal transplant, it costs much higher. You're not going to get a refund, and you're going to have to pay annually about 5 to 10% of your initial investment to maintain it. These are what the numbers tell us. If you look at the quality of life after stroke intervention, you give the patients and society a boost of 30% in the quality of life, compared to a boost of 11 to 17% when you perform a renal transplant. Again, neurointervention is being given peanuts relative to the showering of money that is being dedicated to the transplant service. And I think the decision here is not based on numbers. It's based on something that is probably non-economic. However, I presented to you real life situation where most of us would choose to. So this is where I got my first point. If you look at the burden of disease, which is calculated by DALYs or CALYs instead of the DQ, this stands for Disability Adjusted Life Years. And CALY, which is QALY, stands for Quality Adjusted Life Years. This is a metric that is used by the World Health Organization and many decision makers when they want to distribute resources. And if you look at the disease burden, you'll notice that the number 1 burden is ischemic heart disease. And stroke is pretty close. The burden of stroke is even higher than all other neurological disorders. So it's a top 2 burden of disease. And this is noticed with developed countries as well as developing countries. Stroke is number 2 when it comes to burden of disease. And also notice that transplant or renal disorders don't reach the top 10. So that's where I got my first point. So the burden of disease of stroke is much higher. Now, the other point I wanted to make is that if you're going to do stroke intervention, there's a closed window for treatment. It is either you treat now or never. While for transplants, the window remains open because you can dialyze these patients. So the urgency is much higher with stroke intervention. So that's the other point I wanted to mention initially. And then the other thing, if you neglect a stroke, the price is very heavy. If you neglect a patient in renal impairment or on dialysis, the price is heavy. However, it's not as heavy because you do have an alternative, which is dialysis. So basically, it's a no-brainer. Stroke intervention, this is how it fits in the general scheme of healthcare. It treats a high burden disease. It's economically smart to invest in stroke intervention, and the return to society and the quality of life and boost of quality to society is significant. And I don't think it can be matched by the resources being dedicated to oncology or transplant, which command significant resources, although the numbers don't justify that in relative terms. Now, let's talk about stroke care. Where does stroke intervention, or how does stroke intervention fits with the general stroke care? We don't want to overemphasize stroke intervention. So stroke intervention is needed in two areas: in the first 24 hours and later on to prevent further strokes beyond the 24-hour window. In the first 24 hours, if we apply our selection criteria, we basically end up with about 10% of patients being eligible for stroke intervention. So let's not forget that most of the stroke care is not stroke intervention. 90% of people are treated medically through education and other stuff. After we work up a stroke patient, most of the time the cause of stroke is cardiac. But sometimes you have people who have stenotic blood vessels, and about 15%, and those might be candidates for neurointervention to help with. So overall, 10 to 15% of stroke patients might need neurointervention to help them. 90 to 85% will not need neurointervention, but will need medical attention provided by other services, primarily by the neurology service, which bears the heavy burden of taking care of these needy patients. So that's the second part about the big picture. We talked about how stroke intervention fits in the overall scheme of healthcare, and we compared it to the transplant service and the oncology service. So let's recap. We started off taking on all of healthcare, and we compared stroke intervention to high-profile services such as the transplant service and the oncology service. We narrowed our focus to stroke care, and we noticed that stroke intervention is involved in about 10% of all stroke patients. And now I think it's appropriate to walk you through what a patient goes through before they land on a stroke intervention table, because that's also, I think, relevant. Stroke treatment, stroke intervention doesn't start in the angio suite. It starts with noticing symptoms, which most of you are aware of, such as speech problems, loss of motor function, or loss of sensation. So when that happens, we end up asking ourselves, what are our choices? We're faced with two choices. Either choice one, do nothing now, but try to prevent future strokes and their consequences later on. Or choice two, which is do something now and also try to prevent future strokes. The first choice was the only choice before 1996. So that was the practice. And after introduction of IV TPA, some centers started actually being actively involved in treating stroke patients instead of just relying on rehab and prevention. And then in 1999, the Mercy device came and people started actively trying to intervene in these patients. However, most centers, even with these developments, because of the lack of evidence, continue to do nothing except prevention and rehab, which are important, until 2014. And then all of a sudden, there was a noticeable shift in this choice. So although it might seem elementary and obvious that this is the choice now, it wasn't very obvious before. And this is sort of, these dates are important dates to keep in mind. So now we actively treat patients during the acute phase, and also actively try to prevent further strokes and continue with rehabilitation afterwards. I think that perspective is important. And you might ask me, how do we choose which approach? Not everybody's eligible to the active treatment in the acute phase. These are the questions that we need to ask ourselves. What's the time of onset? Is there bleeding? Is there something to save? Or is it too late? And is there something fixable? Or is this just an academic discussion? And the way to answer that, usually 24 hours is the time window that we're talking about in most cases. And blood needs to be absent. And this is a case that's not eligible for TPA or neurointervention. And the brain needs to look decent. This is a patient with an established stroke, so this is an exclusion. This patient is not a candidate for stroke intervention or TPA. And the last criteria is that we need to have something fixable. For me, it is a large vessel occlusion. Notice that the middle cerebral artery here is open. The middle cerebral artery here, we have a gap. So there's probably a clot causing this. So if we have somebody within 24 hours, no blood, and the next step is neurointervention. Okay, so we selected a patient and now we're in the angio suite. So what to do? What we basically do is plumbing, more or less, and we try to open up a vessel. That's basically what we try to do. And we have at our disposal a lot of devices and material. I'm going to go over it, and this is a little bit of a technical part and device-oriented part that I did not want to start with and emphasize. I thought it was important to talk about the big picture and talk about what happens to patients before they reach the table, and not let this part of the discussion dominate my talk. But basically, we can open up vessel chemically, and it's similar to what a plumber does when they put material to dissolve the clogged tubes. And the best agent that we have is TPA for that. It can be injected intravenously, but we also in the angio suite can deliver a higher dose intraarterially. In selected patients, we still do that. Mechanically, it's again very similar to plumbing. There's a number of devices that are available to us, and we're going to go through a few of them. These are just a few of the names: the Mercy device, the Phenox, NeuroNet, Catch device, and so on. This is a Mercy device. It looks like a corkscrew, and what you're trying to do is to pass the clot, deploy your device, and hope that the corkscrew engages the clot and pulls it out. Again, this is a close-up look at the clot removed by a Mercy device. This device did not succeed that well, and it was replaced with superior devices. And this is how it looks on close-up. This is the Phenox device. I'm sorry, this is what a Phenox device tries to resemble. It looks like a brush, and this is a close-up of what it looks like. And what you're trying to do is to catch and remove the clot with a device that resembles a brush. The Catch device resembles a net. Currently, they remodified that. It doesn't look like a net, but the initial generation of the Catch device looked like a net. And it's basically trying to catch like a butterfly or a clot with this device. There are other devices like the Alligator and In-Time Retriever, and they try to snare the clot and remove it. These are gooseneck devices, and you can imagine them collapsed inside the tube, but if you push them outside the tube, they take this shape where you try to grab a clot and remove it. Not very successful, but we're including it in the discussion. This is the Alligator device, where you deploy this at the clot, and then you squeeze these with a catheter, and then they clamp down on the clot and try to remove it. Again, not very successful. It was more successful in removing embolized coils, but not clots of fibrin and platelets. This is an example of a detached coil and attempts to remove the coil using the Alligator device. This is another in-time retriever. Again, sort of similar, trying to grab the clot and remove it. There are other techniques which were developed that used aspiration. The most successful is the Penumbra range of products. And these basically function like a vacuum and try to suck out the clot. This is a tube and a separator. Now we use the tube without the separator, but the objective is to actually cross the clot and get the tube as close as possible to the clot and try to aspirate it through a large diameter tube. And this is a close-up of what it looks like. These are large diameter tubes that keep getting larger because we notice that their efficacy is better the wider they are. Other devices is like the fast funnel catheter, and this uses the Bernoulli principle. A jet of water is injected from this nozzle backward. The speed of the water injected through the Bernoulli effect sucks the clot with the water. There's a negative pressure that is created by this. The pressure here, because of the fast moving water, is lower than the pressure outside, and this gradient pressure pulls the clot in. The jet fragments it and takes it out. Very nice idea, but practically it wasn't that effective, at least for stroke. It's used to declog dialysis catheters, but not really, it has not found its place with stroke intervention. This is another device, the funnel catheter. Sorry, the first device was the angiojet. This is the funnel catheter, and basically it tries to suck the clot. Early on, we didn't have these devices, so people tried to disrupt the clot with maceration, and we used whatever was available to us. Early on, we used microwires to probe the clot. Snares that I showed you. We tried to fragment the clot with balloon angioplasty, and the Omniwave was a device that was developed. This is a balloon, and you can use balloon to fragment and open up vessels, as you can see in this illustration. But the Omniwave is a wire that vibrates at ultrasound frequency, and it's used to fragment the clot. In principle, very attractive. In practice, it didn't really find a place in current practice. So it looks very crowded, and you have a lot of devices. Some of them are shown here, some of them I mentioned in the prior slides. And what happened to all these devices? Most of them didn't make it through. The two front leaders in the race were the stent retrievers, which are basically stents, but you can pull them out, and the aspiration catheters. Most people use one or the other, or a combination of the two. So these are the two devices that succeeded in actually separating out from the crowded device market. Of course, like anything else, when you have a certain device, you're tempted to actually combine them together. So Mercy device was developed in 2004, and later on the aspiration was developed in 2009. Stent retrievers came into the scene in 2012, and then people were tempted to combine them, stent retriever with aspiration. Then you need to consider the cost. So people went back to using only one technique, like the ADAPT technique, to try to cut the cost. But you need to tailor it. There are pros and cons of combining these techniques together. This is what you want to achieve. You want your device to remove what was blocking the vessel. Like fishers or hunters, you take these trophy shots, and this is our personal best. This is the 7-centimeter long clot that we removed approximately 4 to 5 months ago. So this is our trophy clot. I mentioned that the two front runners were the stent retrievers and the aspiration catheters, but again, there are special cases where you might need to use other techniques. For example, refractory strokes where the stent retriever and the aspiration doesn't work. Sometimes there's a place for angioplasty. You can use a plain angioplasty balloon or a drug-eluting balloon. And we're increasingly using that in patients who have underlying stenotic lesions because the other options are really not attractive. And sometimes you end up needing to leave a stent. Instead of using the stent retriever where you deploy a stent to remove it, you deploy a stent and keep it there to keep the vessel open. And these are used in refractory cases. This is not ideal, but these are salvage techniques in very difficult cases. This is a case where there's a blocked vessel. It was reopened, and it was reopened with a stent, as you can see here. It was deployed and left there, not removed, like we typically use with most stents, where we deploy the stent and remove it with the clot. Because of the tremendous success of thrombectomy, people have been testing the boundaries, and initially we were excluding octogenarians, but because of the huge success in people below 80 years old, we now don't exclude people above 80. It's a little bit more complicated. The results are not as favorable. However, we still think that the benefit carries over even beyond 80 years old in selected cases. These are difficult cases, so you might do novel or advanced techniques to get the job done, such as puncturing the carotid directly. Another special case is people beyond the 24 hours. And again, because of the tremendous success within 24 hours, in selected cases, we might consider intervening even beyond the 24-hour window, especially for the posterior circulation. Again, I'm continuing the same theme. All the data are for patients above 18, but I don't see a reason why we can't push the boundaries downward age-wise. And we actually just did our first pediatric patients about a month ago, and we were happy with the results. If you look at the literature, I think the youngest patient that had neurointervention for a stroke was 18 months old. Another special case, if the arteries in the groin are blocked, you can access the vascular tree through other pathways. One upcoming trend is actually using the radial artery, which you can use for intervention, including stroke intervention. This concludes my talk. Thank you very much, and I appreciate the opportunity to talk in this forum to this diverse audience. Bye-bye.
Thank you so much, Dr. Riyadh, for the interesting talk. You made it so easy, even for the non-neurointerventionists to understand. I don't have any questions on my side, except one I would like to ask, and then I will refer to the rest of the questions. Do you have any hyperbaric oxygen in the King Faisal Specialist Hospital? And if that's the case, do you use it around your cases?
I'm sorry, the voice broke up, so I missed the question. The question is, do we have what?
Hyperbaric oxygen.
Well, it's available.
Because I know some.
It's available, but we don't use it. There are a few cases where it's been used for chronic ischemia, especially post-surgical or post-embolization. But for acute stroke patients, we haven't used it.
I know the Japanese actually do use it in some of their centers. So maybe I'll open the floor to the questions, and maybe Dr. Adel could probably look into those and see if there's any question that you could forward.
Thank you very much, Riyadh, for wonderful journey. Let me take the advantage of being a co-chairman, and I would like to take your opinion on this. Clearly, stroke is a big burden. The numbers in favor of strokes, interventions are more successful in numbers even than the cardiac. But things are not evolving in terms of healthcare as much as we want. Why is that? I mean, you brought the discussions comparing that to transplants or even to our colleagues in cardiology. What's your thought on that? And I know this is a tricky question, but I want to hear your opinion on this.
My opinion, it's a no-brainer. I think how things evolved were probably not based on actual economic and quality of life decisions, and probably the engines behind how things are currently running was probably dictated by how energetic the people were pushing for it and how they can sell certain things. But if we take the emotions out and just do pure analysis, it's a slam dunk. There's no question that stroke intervention is one of the most impactful medical interventions you can do in any tertiary center. And I think very few things can compare to it. Maybe trauma, maybe CPR, I don't know, but it's very difficult to beat the impact that it has. I try to present it in a way that is relatable to most people, which is when you make a decision about investment, what are the things that you look for? And for me, something that you invest in and you don't need to maintain and the impact is tremendous, is a no-brainer. And I think it's just we need to carry this message through and wait for culture. Changing cultures take time. Let me just compare it to something that sociologists do. It's not related to medicine, but to change mindsets and change attitudes, sometimes it takes 2 generations. That's what people have found when you want to educate a whole society. And maybe that's what we're facing to actually get people energized. We might need to be just stubborn, repeat the message, and don't expect immediate results, and don't be frustrated and persuaded not to keep telling this message. That's what I have.
Advocacy. Dr. Cheif, your thoughts on this?
I don't have actually any adds to what you guys said, and I totally agree with what has been stated. And the key in anything you do, I think, is being persistent, because as any physician, being challenged with these cases, time-sensitive cases, if you don't be patient and persistent to the results, you could get frustrated and quit quickly. So I totally agree with what has been said. We have few questions that we could probably throw on the table for Dr. Riyadh to answer. One of them is from anonymous attendee. The question is, what are the complication rates for intravascular placed heart valves? From your experience, of course.
Heart valves?
Heart valve should be asked to cardiologist, but that's what question being asked from anonymous.
I can't answer that question.
All right, here we go.
So for stroke intervention, I usually quote a 10% complication rate, just to make it simple. I think the other thing that we need to keep in mind is that when you're dealing with stroke, the family they're really overwhelmed with a lot of information. And I think your message should be very simple and not too complicated. So I round it around and just say 10%, and you don't need to be precise. And just remember that these people are probably in emotional overdrive, and they're probably not going to remember everything, but at least give them a summary of the main details. Regarding the valve, heart valve, I can't answer that, so I apologize.
Okay, there's a question from Ahmed that probably Dr. Adel could handle, because that's towards your subspecialty.
Yeah, so there was a few questions about stroke prevention and what do you do in impending stroke. And I'm just gonna give, this is a whole topic by itself, but I would say if it is an acute stroke within the first 24 hours, then we would assess them whether they're candidates for reperfusion or not, based on what Dr. Riyadh said, is a patient candidate for IVTPA or mechanical thrombectomy? And if not, it's the standard, stroke care, antithrombotics, depending on the cause. And then you try to find what is the cause. Is this related to cardioembolic? In this case, the treatment would be anticoagulation, or is this atherosclerotic? And if there is a large vessel atherosclerosis, then you might need to do the interventions that Dr. Riyadh talked about for revascularization. And then you address the risk factors accordingly. There was another question about when you see multiple lacunar stroke, what should you do? Again, it's the same thing. You try to identify the underlying etiology. Yes, lacunar stroke, you'd think about small vessel, but in about 5 to 10% of those, it could be also related to cardio embolic sources, which would change your management. So again, look at the vessels, look at the heart. I think that was about it.
There's additional question. Actually, there's additional question from anonymous attendee. It says, is surgery for treatment of venous reflux being replaced by endovascular alternatives?
Venous reflux?
Yeah, this is what it says. Is surgery for treatment of venous reflux being replaced by endovascular alternatives? So I'm not sure what's the question about.
I have a couple. The venous reflux that I'm familiar with is actually for the varicose veins in the legs, and endovascular treatment is actually gaining a lot of ground there. And related to neuro, I'm not aware of venous reflux being a significant problem. But let me rephrase the question, something related to the talk. Is there surgery for acute stroke? And the answer is yes. Some cowboys actually do craniotomies and remove the clot surgically. And I've seen a few examples of that, but this is not standard of care. So in some centers, a neurosurgeon is willing to actually open a vessel and remove a clot. But that's not standard of care.
Yeah. If you allow me to add to that, is the craniotomy for malignant MCA, which is an effective life-saving intervention, and people younger than 60 years old, it can also improve the outcome. So this is, again, a different topic. Dr. Cheif, I think, was there any other questions that we did not address?
Yeah, I could see there's a question on the recommendation on the pre-procedural anticoagulation protocol in cases of PCI, of course. So what's your protocol, Dr. Riyadh, for the cases you do? The anticoagulation protocol.
What do you mean, for acute stroke? Or
yeah.
It seems the question goes, for patients going acute PCI, probably for acute, of course, stroke, yeah.
Well, I think it might be miswritten. My understanding is they're talking about pre-procedural, is there any anticoagulation needed?
We try to avoid heparin for acute stroke intervention. If we expand the discussion beyond stroke, if we're treating AVMs, non-bleeding AVMs, I often give heparin, maybe a little bit subtherapeutic. If I'm treating aneurysms with a stent, then you have dual antiplatelets, and I also intraprocedurally have them fully anticoagulated. Special cases, dural fistulas, when you actually have significantly reduced the flow in the fistula and you have stagnation in the venous side, it might be wise. Again, there's no universal opinion about this, but in my practice, when there's stagnation in the venous side, I often anticoagulate them for a few days, at least 2 days, just to prevent excessive thrombosis. So those are the sort of my practice when it comes to anticoagulation. Stenting, carotid stenting, I only anticoagulate during the procedure, but they're covered with dual antiplatelets before the procedure and carry that afterwards.
There was one question about indications of stent placement during the procedure. After thrombectomy, do you put stent in some cases?
I avoid it at all costs, but in some refractory cases, you're stuck with a stent. The thing that I've noticed that actually I want to share is that if you do enough of these, I think you can notice which ones are going to need a stent early on. You're going to see the behavior of the stent retriever as you pull it. And if you get a behavior that suggests an underlying stenosis, I think I'm going to avoid a second thrombectomy, because I've noticed that if you actually do a second thrombectomy on an underlying lesion, it's not uncommon to end up with a dissection. From seeing a few sort of frustrating cases, if you suspect a stenosis after the first thrombectomy, maybe you'll have a lower threshold for doing angioplasty and stenting instead of putting the patient through a second thrombectomy.
I get a question for you as well, Dr. Riyadh. Have you done cases through transcarotid approach, direct puncture of the carotid?
Not for acute stroke. I've done them for AVMs, and I've done them for aneurysms, but not for acute stroke, fortunately. But the scenario where you need to actually puncture the carotid during acute stroke is probably when you cannot navigate the aortic arch. So it shouldn't be your first line. In my opinion, your first line is either going to be the groin, and in some centers, the radial seems like a decent first line if you have enough experience. The carotid shouldn't be your first line, but it could be an option if you actually fail to go through the arch, which is very uncommon, but just keep it in mind, it's an option.
There was one question, will the hand move? How effective is the thrombectomy, and will the patients be independent? And how to prevent brain magnetization?
On-table improvement, whether it's hand movement or talking, is a very encouraging sign. It's actually a very excellent sign. And just to share with the group, I've had one or two patients where they were mute, and then after we removed the clot in the MCA, the left MCA, the first things that they came out of their mouths were obscenities against me. And some of them started kicking me. That's rare, but those are welcomed aggressiveness from the patient.
Yeah.
When I see
you think that's a good sign, right?
My job.
Okay, there's a question probably more towards neurology by Y. Ali. His question is, what are the latest updates on cerebellum strokes treatment due to small vessel disease?
I think small vessel disease is the same, whether it's in the cerebellum, brainstem, or in the basal ganglion. Especially you look for any underlining conventional vascular risk factors. If the patient is young or there is something atypical, then you look for the uncommon causes of a stroke. But there is no distinct management of cerebellar lacunar stroke. Now, if the cerebellar stroke are large and causing brainstem compression, and now we're talking about the subacute phase, then you may consider surgical options for decompressive craniectomy. I don't know if that's what he was referring to, but those are not small lacunar stroke.
Okay, this is also another question towards probably more of towards the neurology. In centers where there is no neuro-interventionist, does brain CT perfusion has any role? Would you find it helpful for you as a neurologist in case of there's no neuro-interventionist? Because the purpose of doing this is to see how much salvageable.
Well, the usual window for IV TPA is 4.5 hours. But recent data has came from 2 studies which showed that if you do advanced imaging using perfusion, that you could extend the window up to 9 hours or perhaps even more in very selective cases. So the way I would approach those, doing something is better than nothing. But for large vessel stroke, it's better to send patients somewhere where they can do the interventions. But if you are in a very distant remote areas and you have the access to this perfusion imaging and somebody who can interpret, then you might use that to extend the window, or perhaps in times where you're not certain about the onset. But in cases that they present very early, I usually go with a plain CT scan if you're, if you know how to read them. Riyadh, you want to comment on this as well?
No, I don't have anything to add. Perfusion, I think also has maybe a prognostication or academic value. Not necessarily for clinical practice. The other thing, if you're contemplating transfer to another hospital, some people use collateral imaging. If the patient has good collaterals, even if you're a remote area, you might be able to actually still send the patient elsewhere, because the collaterals are going to give you some leeway to actually transfer the patient. So there might be value there. So if you have an exit strategy or somewhere to take the patient later on, that imaging can tell you whether this is a patient who can actually tolerate the trip or not.
Yeah, and my let's say my suggestions or advice for the person who asked that is to have connections or arrangements for centers where the thrombectomy ahead, before you get the cases, so it's a smooth transfer.
Okay, I think on the list there's one final question talking about the efficacy of thrombolysis in devastating wake-up stroke.
This is regarding thrombolysis or thrombectomy. So so my understanding, if he's referring to devastating by deficit, bad deficit, but the CT scan still looks good, then many of us would treat those patients based on imaging. But if the CT scan, there is an established infarct, as Riyadh shown, then perhaps there's nothing to save. And in this case, you don't want to do more harm by causing hemorrhagic transformation. Your thoughts, Riyadh, on this? Or?
Yeah, I don't think devastating is well defined. I don't know what it means, but we don't, I think it's not part of the exclusion criteria for thrombectomy. So if you have somebody who has a stroke within 24 hours, so time is more important, absence of blood, a good-looking CT, and a large vessel occlusion, whether it's devastating clinically or not, I think those are indications to do thrombectomy.
Yeah. Okay, I think we tried to answer most of the questions. Thank you for having you both, and thank you to Professor Pooja, Khatri, who couldn't be with us in the discussion due to timing difference. Keep up the good work, and see you again, hopefully, in the next webinar. Thank you all, and have a good evening.